tension pneumothorax and role of suction in its management, which will be taken by Dr. Silpi Singh. So I'll invite Dr. Silpi to take over the dais. This arrow key.
Good evening, everyone. My topic for the day is tension pneumothorax and the role of suction in its management. So, as we know, pneumothorax is as the name suggests, it is the presence of air between the two layers of the pleura. We have two layers of pleura in our lungs. One is the parietal pleura that is present parietally, and one is the visceral. Now, closed pneumothorax means that the opening for the air to go inside the pleural cavity is towards the lung. So, any kind of trauma to the lung, either most commonly due to surgical interventions, there is a leak that is present as denoted by the yellow arrow in the diagram. So there is a leak at the surface of the lung that results into the air going inside the pleura. That is the closed pneumothorax. Herein, the pleural cavity pressure is less than the atmospheric pressure. Second is the open pneumothorax. So the opening that is causing the air to go inside the pleural, in between the pleural membranes, is present at the level of parietal pleura. So the air, like in the cases of open chest trauma. So what happens is the air will go inside the pleural cavity and that will result into open pneumothorax. Since it is in direct contact with the atmosphere, so the pleural cavity pressure will be equal to the atmospheric pressure. Third is the tension pneumothorax. Now, the closed pneumothorax or open pneumothorax can result into tension pneumothorax. Tension pneumothorax is a condition wherein the air is present in between the two layers of pleura, no matter from where it has reached. Either it has reached from the parietal pleura opening or visceral pleura opening. But the thing is that the air is present in between the layers of pleura, that is not going out. There is a one-way valve present that will result in the air entering into the pleural cavity during inspiration but not getting out during the expiration. Why only during inspiration? Because there is a negative pressure during the time of inspiration. When we inspire, -8 centimeters of water is the pressure that is there in between the layers of the pleura. Now what happens is, till the point where the pressure inside the pleural cavity is equal to the atmospheric pressure or less than the atmospheric pressure, the air will go out. But if the pressure has reached to a point where it is more than the atmospheric pressure, at that particular point of time there will be tension pneumothorax. हवा अंदर आएगी इंस्पिरेशन के टाइम पे, बट क्योंकि प्रेशर अब ज्यादा हो गया है तो अब it will not be able to move outside during the expiration. Now, tension pneumothorax is an emergency condition. Tension pneumothorax is an emergency condition where one-way valve air leak develops either through the chest wall, that is the open pneumothorax, or from the lung, that is the closed pneumothorax. It enters into the pleural space during expiration and doesn't get out during expiration, that is the positive pleural pressure. Now, the causes of tension pneumothorax include traumatic or non-traumatic causes. Traumatic causes are like penetrating chest trauma, any kind of blind chest trauma, iatrogenic during the time of surgical interventions, non-traumatic during positive pressure ventilation, condition, in COPD patients where spontaneous bulla rupture is there, malignancies, and in cases of severe asthma. Now, what is the pathophysiology behind the signs and symptoms of tension pneumothorax? Now, air leak has occurred in tension pneumothorax, maybe due to open, due to close, any reason. Air leak is now air is present in between the two layers of the pleura. What will it do at the point where it has reached where its pressure is more than the atmospheric pressure? The lung will collapse. When the lung will collapse, the whole of the mediastinum will shift to the opposite side. The pleural pressure is raised. Now this will cause a pressure to the heart that will cause the decreased venous return, because our mediastinal cavity comprises of two lung cavities and one heart cavity. So if there is increased pressure at the level of any one side of the lung, it will push the whole mediastinum to the opposite side and give pressure to the heart compartment. That will cause the decreased venous return, decreased cardiac output, ultimately resulting into hypoxia and cardiac arrest. Now, what are the clinical features of tension pneumothorax? Now, because of the hypoxia, because of the lung getting collapsed, there will be shortness of breath, there will be tachypnea, there will be absent or decreased breath sounds, there will be sharp pleuritic chest pain that will be radiating to ipsilateral shoulder and back. Because of the mediastinal shift, there will be a tracheal shift, there will be hypoxia. Because of the pressure to the heart, decreased venous return and decreased cardiac output, there will be jugular venous distension, hypotension, resulting into acidosis, tachycardia, and hyperresonant note on percussion. Now, the radiological features. It's an emergency condition. Tension pneumothorax is an emergency condition. We are having radiological investigations for the same, but we don't have to wait for any kind of imaging studies. It is the diagnosis is purely clinical. Ultrasound can be done. That is 94% sensitive and 100% specific, useful in unstable patients. Then the radiographic evaluation is recommended only when the patient is hemodynamically stable. That involves a chest x-ray to confirm the diagnosis. CT can be done if the diagnosis is unclear on chest x-ray, and it is the most reliable imaging study for diagnosis of pneumothorax, but it is not recommended for routine use. You have to make the clinical diagnosis and manage the patient accordingly. Now, this is the pictorial chest X-ray representing the left pneumothorax. So, on the right side that we are seeing, we are able to see the bronchovascular markings and the trachea and the mediastinum shifting towards the right side. On the left side, there are no bronchovascular markings except at the area where it has been marked as the collapsed lung. So the whole lung has been collapsed to that particular point, and in the rest of the areas is taken over by the air in the pleural spaces. Next diagram shows the left-sided pneumothorax. Again, on the right side, we are able to see bronchovascular markings, trachea getting shifted towards the right, and the collapsed left lung. This is pneumothorax on the right side. Collapsed lung is seen on the right side, mediastinum shifted towards the left, and the bronchomuscular markings that is seen on the left side. Now, what are the ultrasonographic features for the diagnosis of tension pneumothorax?
Video separate upload करना. Next. Arrow.
So normally when we put a linear probe of ultrasonography machine over the chest, there is a normal lung sliding signs. The shiny pleura will be seen sliding from side to side under normal circumstances. That is the normal feature of a normal lung. Now, if there is a pneumothorax, there will be absent of any kind of lung sliding, and the lung sliding will be absent, and no comet tail appearances would also be seen. Then second thing that we are able to see in the ultrasonographic features of tension pneumothorax is a barcode sign. When we put our ultrasonographic probe over the chest, the linear probe, under normal circumstances, we see a seashore sign. There will be a shiny pleura, and on the both the sides of shiny pleura, we'll be able to see two different zones, sea and shore. Compared to sea and shore, but when there is pneumothorax, there is no differentiation between the two sides of the pleura. That is, it is giving appearance of a barcode or the stratosphere, and it is known as a barcode sign or the stratospheric sign. Now this is the CT representation of the pneumothorax. Now, what is the management? So the first thing, you don't have to wait for any investigations. If clinically you suspect that it is a tension pneumothorax, immediately you have to put the needle, you have to carry out the needle decompression in the second intercostal space in the mid clavicular line using an angiocatheter. That is your normal IV catheter जो है उससे we have to 18 gauge or 16 gauge catheter can be inserted in the second intercostal space, and after needle decompression we can carry out a chest x-ray to confirm it and then place the intercostal drainage tube. Apart from that, you have to maintain the airway, breathing and circulation. Give 100% oxygen, because by giving 100% oxygen will in a way carry out the process of denitrogenation. So if denitrogenation is done, the intensity of pneumothorax will be reduced to some extent. If it is an open wound, means after the open pneumothorax, tension pneumothorax has been resulted, we'll cover the wound with a airtight occlusive bandage and the plastic sheeting, and we should avoid positive pressure ventilation initially till the chest tube is placed, because if you will give positive pressure ventilation, the pneumothorax will further aggravate, because wahi logic rahega ki air will go inside but it will not come out. And if it doesn't get managed by the needle placement of intercostal tube, then the last thing that we are left is the surgical management. Now, what are the differential diagnoses of tension pneumothorax? Pulmonary embolism, acute coronary syndrome, aortic dissection, myocardic infarction, pneumonia, pancreatitis, rib fractures, and diaphragmatic injury. Now, the complications of tension pneumothorax, the air that is present between the pleura, it can result into pneumopericardium, pneumoperitoneum, hemothorax, bronchopleural fistula. During ICD placement, there can be damage to neurovascular bundle. There will be pain and infection at the site of ICD insertion. There will be empyema and pyoneumothorax. Now, we have placed the ICD. Now, there are different types of methods of draining the pleural air through the ICD. So, for that, we are having different kind of drainage systems and different kind of suction systems. So the drainage systems that are available, they generally have three chambers. First is the collection chamber that will exit from the patient's chest incision and will connect to the drainage, will get connected to this collection chamber from the pleural space. Second is the water seal chamber. Now, water seal chamber has been devised so that there is a one-way valve that will allow the air to move from the patient's pleural cavity to the water seal, but will not allow to air to re-enter back during the time of inhalation. And that is why it is the water level for the water seal chamber is kept at 2 centimeters mark. So why 2 centimeters? Because if it is more than 2 centimeters, then the patient will be unable to expire. The air will not be able to come out, because we have to keep a pressure that is lower than what is the pressure inside the pleural cavity during the time of expiration. If it is less than 2 centimeter, again, it is an ineffective seal and the air will re-enter into the pleural space. And the third chamber that is used is the suction control chamber. Generally, what we see inside that ICD bag, ICD bags generally has only two chambers: the collection chamber, where the pleural fluid or air or pus gets pleural fluid or blood or pus gets collected, and the water that is outside it, that is the water seal chamber, to allow the air to come out of the pleural cavity. Now, the drainage systems that we are using are generally of two types. One is the underwater drainage systems that are of two types. We are having glass bottle systems. like single, double, or triple glass bottle systems, or we are having plastic bottle systems like Plurvac and Thorasil chest drainage unit. So this is the pictorial representation of the glass bottle system. One bottle, two bottle, and three bottle system. Now the one with the blue top, that is the Thorvac system, Thorasil chest drainage unit, and this that is the one downstairs is the Plurvac drainage system. These two are the plastic collection systems, and these one bottle, two bottle, three bottles are the glass drainage systems. Now, one bottle collection system. So this is the one first bottle. First diagram is of the one bottle collection system. Single bottle is there, so that will act as a collection container also. That will give the water seal also. So the chest tube is connected to a rigid straw that is inserted through a stopper and into the sterile bottle, and the tip of the straw is 2 centimeters below the surface of the saline solution, and the stopper should have a vent so as to allow the pressure to get released when the pressure gets built up, and this is good only for uncomplicated pneumothorax cases. Second is the double bottle collection system. So in double bottle collection system, there are two bottles. First bottle will act as a collection bottle for the drainage, and the second bottle will provide the water seal for the air vent. If we want, then we can attach the suction system also to the second bottle of the double bottle system, and the degree of water seal will not increase as the drainage accumulates, because there are two bottles. In one, the fluid blood or pus will get collected, and in the second bottle there will be a water seal, so air will get drained through it. Now the third is the three bottle collection system. This is the three bottle collection system. So on the first bottle there will be a collection unit. Second will act as a water seal to allow the constant movement of air, and the third is the suction that will give a negative pressure suction so as to drain in the conditions of large pneumothorax. And suction pressure is generally kept around 15 to 20 centimeters of water, or 3 to 5 kilopascals, and the amount of the negative pressure in the system will be equal to the depth to which the straw in the suction bottle is submerged below the surface. If more suction is required, the straw has to be inserted more deep in the suction chamber so as to give a more negative suction pressure. Now, the suction systems are generally of two types. We are having a wet suction system. This is the picture of the wet suction system. Now, it will control the suction by the level of water in the suction control chamber, and it is generally been set at minus 20 centimeters for adult. Less is the water in the chamber, less is the suction. जैसा थ्री बॉटल सिस्टम में था, जितना स्ट्रॉ पानी के अंदर डालेंगे उतना ज्यादा सक्शन होगा. सेम इसमें है. Gentle bubbling in this chamber because it is directly attached to the suction device, and it is better for large pleural effusions. So the D is the collection chamber, C is the water seal chamber, and A, the most leftmost part is the suction control chamber. Now this is the dry suction system. इसमें there is a regulator to adjust the amount of suction, and it also responds to the air leaks to deliver the consistent suction to the patients. And the rightmost part is the collection chamber, as it was there in the wet suction system. In the middle there is a water seal chamber, and in the dry there is a suction regulator. That orange colored structure, that is the suction regulator. Now, this study was published in European Journal of Cardiothoracic Surgery. about whether to attach a suction, whether suction or non-suction to underwater seal drains following the pulmonary operation. Matlab after pulmonary surgeries, we put the ICD. So whether to attach it to the suction or to not to attach it to the suction, this was the study done by them, and they concluded that there is no necessity to use suction in most of the cases because it will not decrease the incidence of air leak, but the suction can reduce the occurrence of post-operative pneumothorax resulting from the early air leak. As a result, the early use of post-operative suction might be crucial to specific patient to whom early elimination of residual space is very important. Matlab, it depends on the surgeon's decision. If the surgeon is suspecting that okay, the patient can land up into air leak, or if it is or pneumothorax, the patient can land up into pneumothorax after surgery, so better that after insertion of the ICD we attach it to any kind of suction system, whether dry suction system or wet suction system. Now, some newer advances are there in the field of chest tube drainage. One is the air leak monitor. Some chest tube drainage systems have this feature of present in the water seal chamber itself that will measure the degree of air getting leaked from the chest cavity. This is a recent advance. Then there is a Hemlich wall. It is an this is the Hemlich wall. This is the Hemlich wall. So what we have to do is it isn't just alternative to drainage system. Once we have inserted the ICD, we have to insert this blue part directly to the ICD, and the patient can be mobilized also. It doesn't needs to be clamped. Okay, and we can put the suction also from the other end, the right side wala end. So that is easy for the matlab, better compliant for the patient. Now, this is a recent advance for this tension pneumothorax, that we are using the ICD bag and the ICD tubes. The most recent thing that has come up with is the thoracic drain management using a digital system. This was a study that was published in Journal of Thoracic Diseases, and this is the digital machine for the chest drainage. It has inbuilt suction also. We don't have to apply externally suction. उनका खुद का एक suction system है that will measure the amount of the leak that is there. This is the most advanced thing, and the guidelines was given by the European Society of Thoracic Surgery that if we use this, it will facilitate the recovery after pulmonary surgery. Indicate that digital drainage systems offer several advantages over the analog systems. The advantage of digital drainage systems are these devices lightweight hai, compact hai. They don't require any kind of wall suction because integrated suction pump is there, and it will tell about the air leaks, and it will eliminate the variability in clinical judgment and better decision making. Now, few lines about the bronchopleural fistula. So, bronchopleural fistula is basically a connection that is involving the pleural space and the bronchial tree. So, there are some clinical implications to that. First thing is that because there is a constant fistula that is formed between the bronchus and the pleural space, so there will be continuous air leak. Despite you have placed the ICD, there will be continuous bubbling through the ICD bag, through the water seal, because till you repair it or till it gets healed, there will be a continuous bubbling throughout that. First thing. दूसरी चीज ये है कि if the patient is mechanically ventilated on bronchopleural fistula, there will be auto triggering present, because continuous leak है तो बार बार pressure dip होगा और ventilator को ये लगेगा कि the patient is trying to take the breath. That is why the pressure is getting dipped. What our ventilator detects? It detects the fall in pressure, it detects the flow. So because of the constant flow of air, it will detect that, it will think that patient is taking the breath. So there will be auto triggering. So auto triggering से क्या होगा? Patients का frequency जो होगी respiration की वो ज़्यादा हो जाएगी. More will be the frequency. So what will happen? We'll use more of sedatives because there will be the synchrony will get disturbed. So we will think that synchrony is getting disturbed. We'll give the patient sedatives. We'll give the neuromuscular blocking agents that will further decrease the recovery of the patient. So what can be done is, we can use differential lung ventilation for this patient. We can use bronchial blockers. We can use two different ventilators for this patient. Independent lung ventilation using two different ventilators, and we have to maintain a very very low pressure, a pressure that is below the opening pressure of fistula. Otherwise, the same problem will occur, and it will ventilator will aggravate that pneumothorax. You have to give a low amount of peak, low peak pressures, intermittent ventilatory modes, low tidal volume, and low respiratory rate. Now, in majority of the cases of bronchopleural fistula, it has been seen that we generally put two ICDs. But this was the study wherein the name of the study was the treatment of peripheral bronchopleural fistula with interventional negative pressure drainage. So they have seen what is the role of suction in cases of bronchopleural fistula. So they concluded that the thoracic drainage tube placement with continuous negative pressure drainage is very effective, safe, and feasible method for the treatment of bronchopleural fistula. In cases of bronchopleural fistula, instead of putting two ICDs, we can put a single ICD and connect it to the suction. So that will give a more uh, appealing results in the patient. Now, this is the comparison whether to put a double chest drain or to put a ICD with suction. Double chest drain, okay, it will drain both fluid and air, but it is possible, it is suitable only for smaller and less severe bronchopleural fistula. ICD with suction will provide a pressure difference, so it will drain air from fistula, and significant air leak reduction will be there. And it is useful for large bronchopleural fistula, especially in patients who are critically ill and severely respiratory compromised. These are my references. Thank you.